Hi guys, welcome to another episode. Today my guest is Dr. Mohsen Omrani. Mohsen is the expert in mental health and brain health, and also he's CEO at OPTT Inc. Welcome to the show, Mohsen.
Thank you very much, Gurmeet, for having me.
Yeah, thanks for your time, Mohsen. Anytime there's discussion around the brain health, and especially with what we're going through right now, everybody's feeling that it's going to be biggest challenge for everybody. So I'm looking forward to learning from you and understanding a little bit of how big the challenge is. So tell us a little bit about how does somebody inspired to be a neurosurgeon, somebody an expert in neuroscience.
It was a passion from really the higher school, that I got to learned about the brain and the beauty of, the physiology of the brain that captured me. And when I started medical school, I started, joining some journal clubs and stuff about the brain. And back in 2001, I started, working as a researcher back in Iran at the Institute for Studies in Theoretical Physics and Mathematics. At the same time, I was doing my medical degree, and maybe from the third year of the medical school, I knew that I wanted to follow neuroscience and study the brain. I'm really in the biology. I'm interested in learning how different systems work and how their dysfunction, gives rise to diseases and how we can fix that. So that was the inspiration, to learn how the brain works and find a solution for many of the brain diseases health. And so that's why after I finished medical school, I came to Canada. I started my graduate program in neuroscience at Queen's University. So I did a PhD at Queen's, and I did a postdoc at Rutgers University on computational neuropsychopharmacology. So that's the path.
Interesting. Yeah. So give us a little bit of idea, Mohsen, how big is this challenge that in society, and especially in Canada, this challenges around the mental health, or brain health. Even before COVID, there was all these challenges, people struggling with it. How big is the problem? If you give us a little bit of perspective, what are we dealing with?
Really, the numbers boggle your mind. I mean, you think, okay, there are many specialties in the medicine, cardiology, cancer, mental health. So they are all are in the same size, but that is wrong. I mean, actually, depression is the biggest cause of healthcare costs and expenditure right now. So every year, at each point in time, 1 out of 5 people deal with mental health problems. And through the lifetime, 1 out of every 3 people will experience mental health challenges. And the numbers, I try to combine Canada and US. So to give you an idea, the number would be around 60 million people at each point in time needing health, needing mental health care. But unfortunately, a big challenge is that maybe just less than 40% of those patients who need care, who need help for their problem, actually receive and seek to receive any care for their problem. Which is a big problem. Consider that only half of diabetic patients would seek would seek care for their diabetes problem. So it's a big challenge, and it should be treated heads on. And I will let you continue.
So staggering numbers, very high numbers. So any thoughts on these numbers are more on teenage years or a little bit older, or elderly? Where do you think the majority of these numbers coming from? Any segregation on an age group or ethnic groups, or where is the segregation
Well,
of the data?
there is definitely some differentiation. So the the number was around thinking that mental health challenges among baby boomers were around 25%. Uh, how often they happen. And that number among the millennial and Gen Z is around 63%. So the numbers are staggering, and it's it's really frightening when you think about it, because the demand is exponentially rising, and the supply not only is not increasing, it's actually decreasing. So like half of the psychiatrists practicing today, like 50%, are set to retire within the next 5 years. Just
both
imagine
in the
that.
US and Canada, or just in Canada?
No, both in US and Canada.
Okay.
Well, I mean, psychiatrists are not the only mental health care providers, admittedly, but it's not like that is different. The numbers might be a little different in other things. But so the challenge is that there is no way we can catch up. There is no way we can, train enough mental health care providers, clinicians, to catch up with this number. And that is a big challenge. So it's like unless we really treat this and fight these heads on, it's gonna catch us empty-handed in the future.
So why do you think, my first question, why do you think the number is so high Gen Z and those two age group you talk about? What is triggering that those numbers are just so high in those two groups?
Well, to be fair, I'm not a psychologist. I don't or sociologist to know that there are lots of social media is a big factor. The fact that you are constantly comparing yourself to others causes anxiety, right? And a lot of things that were really limited before are now completely widespread. Before you would dealing with a few bullies in your high school. Now that those bullies are not limited to your high school, it's like all over social media. So the anxiety is really high. The prospect is really dim. Again, these are stuff that sociologists should deal with. Whether the job security and other economical factors are really pressing. But yeah, I mean that is that is beyond the point. The point is that we now have the problem. We definitely deal with the root of it, but we should think for a solution to deal with the problem that we have. We deal with the hands that we were dealt with.
So this problem was there before COVID, and I've been reading some literature and talking to some experts. There seems to think that this problem is going to get even worse after COVID, but people living at home for last year and a half, they're isolated in different areas. So this is gonna escalate. What are your thoughts on that? How bad it looks, and what's expert in your space are thinking that how bad it's gonna get once it's we're back to get a handle on vaccines and COVID.
It's gonna get really bad. The challenge is that they call this the fourth wave of the pandemic. The first wave is the wave that deal with the urgent parts that people go for COVID, and the second part being a lot of those surgeries that were postponed and all sort of stuff. The fourth wave is the mental health challenge. As you said, the numbers, like there are different numbers that show like more than half of Canadians right now deal with anxiety, because of all the isolation, job insecurity, financial challenges, and so a lot of there are lots of new studies coming out showing like a lot of people feel that COVID has affected their mental health and their sleep pattern and all those stuff. And I just last month I read this article that around 30% of patients, dealing with COVID itself, develop mental health challenges. Now, at the most of the time, we are only looking at fatality. It's like, okay, the fatality is only 2% or 0.2% or whatever it is. But we don't. We tend to forget. I just don't know the latest number in US. I think that is around 30, 40 million, and in Canada should be around 4 or 5 million. I haven't seen the latest number, but just imagine just over the last year, we have increased. I mean, this was a big problem by itself. And we have this insecurity and, this anxiety because of the COVID. On top of that, 1/3 of one out of 3 of the patients who actually caught the COVID would develop mental health challenges as well. So it's going to be a big challenge, and it's important to remember, these stuff are not going to be solved after the acute phase is gone. Like, for instance, there was this study in New Orleans that even 4 years after the Katrina, the hospitalization because of alcoholism and overdose was 30% increased compared to before it. So it is something that is going to have a lasting effect, and is going to, unless we really find a solution, is going to dry up all our resources.
Well, in terms of solution, as you mentioned already, that the problem is getting bigger, and we have a problem where we health professionals numbers are decreasing in this field. This to me is going to get worse. As the people are exiting the workforce, retiring, and the numbers are going up, right? So, how do we get a handle on this problem? Any solutions being talked about with the experts you have access to? Are experts talking about any solutions? Are they seeing there's a problem coming? Are they changing anything, or they implementing something that can tackle this problem?
Well, unfortunately, the official responses are usually very, very slow. We are, especially in Canada, we are really bad in adopting new technologies, right? So, as you know, I mean, I think the only fax machines that are used in the world are used in the medical system in Canada. Between the clinicians and pharmaceutical and so pharmacies. So it is important to realize that how big the problem is, and really think deep about the solution, and not think really about just some sort of momentary relief. So, for instance, naturally, the solution that people cannot see was video conferencing. Seeing your patients, seeing your patients, your doctors online and through video. That is amazing. That does solve a problem, which is the access, right? That is a whole different big problem that especially Canada is dealing with, is access. That's good, but at the same time, that doesn't solve the capacity problem. The 1 hour you spend with the patient, either in person or on video, is 1 hour. Now, your capacity is this much. You want to increase your capacity 4, 5, 10 times. How do you do that? And that is where I really think the technology is here to help us if we know how to use it. Right? Yeah, go ahead.
No, and that brings me to the question that your company OPTT Inc, you guys developed the technology. So if you walk us through how do you guys tackle this problem and how do you help out this problem?
So, as I mentioned, the challenge that we have here is how can we increase the capacity by 4 to 5 times, right? So that means that we should be able to use the clinician's time, very optimize it, so it's just make sure that we are not wasting any time. We are not using the highest person in the chain and the most expensive resources for the simplest problems, right? So the solution should be something that can could be more and more accessible and more applicable by people closer to the patients, whether that is family physicians, whether that is social workers, those people who are lower cost or have more closely dealing with patients, and there are more of them. There are so the challenge is that for instance, family physicians, a lot of them are not trained how to deal with the mental health problem beyond prescribing some antidepressants, some anti-anxiety medications. Anything beyond that, they should refer them to a psychiatrist, right? So the solution really is to find a streamlined and standardized solution that is easy to apply, right? That we can train those that are capable to deliver it, easily learned how to apply it. And that is why we have focused on developing that tool. A lot of companies out there are, whatever they're doing amazing, but they are delivering the care itself. But what we have thought about was that, well, no matter how efficient we are, we cannot, our capacity is going to be limited by the human factors. But if we can actually develop the tool and give the tool to whoever is out there is qualified to deliver the care, they can increase their care capacity. So think of this as having one very fancy imaging center in, for instance, in Toronto to cover whole Ontario, or having X-ray machines in every hospital. So even if your fancy center in Toronto is big, they cannot answer every need across Ontario. But you don't need to do that. You can actually have X-ray machines, ultrasounds, even MRIs in each of the hospital in different cities to handle them. So that is the role of technology. That is the role that we should be thinking. That is how medicine have progressed, developing tools and making those tools available to clinicians and helping clinicians learn to use those tools more efficiently. So that is our vision about how we want to handle mental health challenges like this. But I can explain more how the system works actually.
I see. So what I'm hearing is a lot of process items that around this care is you automate through technology. Is that correct? That you automate a lot of administration tasks, a lot of workflow kind of low administration tasks. You automate that and get the physician to focus on patient more than dealing with all the process issues or dealing with administration tasks to circulate. Is that what I'm hearing?
Sort of. So, for instance, our technology really has two sides. It has a clinical side, and it has the AI side. So, so psychotherapy is, a tool that how is changing the behavior through interacting with your patients, through talking, through learning, and there are different methods of psychotherapy. And psychotherapy is the gold standard of care for mood and anxiety problem. Mood and anxiety problem consists 65-70% of mental health problems.
Yeah.
So, and when we usually talk about psychotherapy, a lot of people think of talk therapy, that you go sit on a table, sit on a chair, and you talk, the clinician listens. There are other kind of psychotherapies, like what we call cognitive behavioral therapy, that rather than what was the source of your problem, trying to understand that, which is like a psychodynamics as they call it, they talk about techniques. That, okay, let me teach you techniques that helps you deal with hard situations.
Gotcha.
Right?
Yeah.
Like, let me just bring an example that makes it a little more clear. So one of the things that they teach in CBT is what they call 5-part model. So the 5-part model says your behavior, your emotions, your physical reactions and thinking are connected with your the environment. So what that means is that just think of a simple action and your reaction to it. Just imagine you are calling a friend. You have called them 3-4 times, and they haven't responded, right? So what is your reaction to that? How do you feel in reaction? Well, it all depends on what you think is happening. If your friend is a sloppy and usually forgets their phone at home, it's completely indifference. I mean, it's like, okay, he forgot it again. But if you know that he is this person who is not getting separated from their phone, then you think, oh, maybe they're ignoring me. And you feel annoyed and kind of sad that why are they ignoring me? What happened? What caused this? And that kind of sad and angry emotions come to you. But if you think that, oh, maybe they're sick and that's why they are not responding, then you become worried, right? So the same action, you calling a friend, they're not responding, could cause a whole different range of feelings in you, depending on what you think was the underlying source.
How you perceive that, why they're not responding to calls.
And the idea is that, so now take this example and try to apply it to different situations. Rather than jumping to one conclusion, try to evaluate, okay, there is possibility that this happened or that happened, and what are the chances that they are really ignoring you? Yes, they might be really ignoring you. What are the chances if they're your close friends, right? Sorry, my son just jumped in. So it all comes back to that kind of cognitive understanding on how your feelings are affected by this mental process. Now, when you go to a psychologist, so they actually teach you this range of techniques, right? And this range of techniques really don't change from one patient to other, right? Like, so like 70% of the time you are in the psychologist's office, they are essentially talking through these techniques. So it's nothing specific about you. It's nothing personal. It's more like a general concept. So the question is that, well, you have this really structured thing, and which you are repeating across multiple patients. Why do you need a psychologist with $200 per hour rate to do that and repeat that to everybody? Why couldn't we replace that with the technology? We have a lot of different ways of guiding people through content and self-guided learning and tutorials. So maybe instead of using the whole 1 hour of that psychologist to spend 70% on that non-personalized part and then the last 30% on the personalized part, let's keep the personalized part and move the general part to what the technology does. So what we have done is that we have developed disease-specific modules, therapeutic modules that they're pre-designed, completely streamlined, and
templated.
Exactly. So the clinician assign a module to the patient. The patients go through the content on their own time. At the end of each session, there is a homework. That's the personalized part. They ask them, okay, do this homework, do this practice. They do it, they write it, and the clinicians only provide personalized feedback on the homework and skip repeating those general content. This way, they can handle 3 to 4 patients in 1 hour rather than just one patient, right? But one thing that is what we have as a medical doctor is really important for me, like any other field of medicine, any solution, any therapy should be first validated. You cannot come up with a solution, and then go and try it on a patient. That is irresponsible, that is dangerous. And that is completely true for mental health problems as well, right? You cannot come up and say, okay, I think this module works perfect. I'm going to put it on and I'm going to test it on my patients. So we do not think that is a good way. So what we have done with our clinical content is, we have a commitment to clinical validation. So any module, that goes on our platform is connected to a clinical trial, is connected to a peer-reviewed article. So when we say, for instance, our anxiety module reduces symptoms by 40%, there is an actual paper that you can go and pick it up, look at the control group, look at the intervention group, see how the symptoms changed in the control group, how symptoms changed in the intervention group, and you can actually evaluate it yourself that, okay, this is, this kind of claim is validated or not. So, yeah, so that is the clinical side of what we do. The other side is what we call the AI and what we call more precision kind of evaluation part of it. A challenge with mental health problem is that it's being practiced the same way as it was practiced like 67 years ago. You go to a family physician, to a doctor, and you have had a fever that has not been controlled in 3-4 days. One thing they do is that, okay, they ask you to do CBC, a blood count, right? They want to see what is your white blood count, what kind of different blood count it is. Then they apply antibiotics, then they repeat the blood count. So this is what we call evidence-based practice. You have an evidence, you make decisions based on those evidences, right? Unfortunately, the challenge is that is not really the case, in psychiatry and mental health. There are no solid ways of measurements. We don't have any solid ways of quantitative measurement and objective measurement of patients' mental status. So that leads to where we are now, that, for instance, the medication is working only on half of the patients.
Mm-hmm.
Because what we really are pulling together under the same umbrella as depression is probably 10 different diseases.
Mm-hmm.
And because we just brought them together under some name, it doesn't mean that any medication that we make for this is going to work for everything under that umbrella.
Mm-hmm.
We really need to try to separate to say, okay, this is depression caused by this. This
Mm-hmm.
one probably does respond to medication. This group of the depressed patients probably don't respond better to psychotherapy. So it is important to have the clear quantitative measurements, and that is what we are trying to do with our AI part. The challenge is that it is challenging though, so I should mention that. So the challenge is that for instance, when you're dealing with a diabetic patient, it is clear what you want to evaluate. You want to evaluate patients' blood glucose, right?
Yeah.
The challenge with mental health is that it's not clear what you want to evaluate. There are a range of problems. We know that a patient with depression, their sleep pattern changes. Their activity pattern changes. Their moving changes. The tone of voice changes. And the way they move their eye changes. The way they make decision changes. So there's a whole range of symptoms that are affected. So there have been this approach that there are teams that they said, okay, we know that the tone of voice changes, so we're going to go test the tone of voice.
Yeah.
Right. So they have built devices that works on the tone of voice. Actually, Amazon released a wearable device a few months ago that listens to your tone of voice and tells you you're happy or not. Right.
Yeah.
But the challenge is that, again, this is one aspect of it. So for you to really have a comprehensive view, you should be actually sampling different parts of this. And that is what we are trying to do using our analytical power and AI power. So we, at the same time that the patients go through the modules, we continuously are monitoring more than 25 different behavioral, clinical, and physiological symptoms and provide analytical feedback to the clinicians about the patient's progress, our prediction of the outcome of the care, and our suggestions on the next step based on the data that we collected in the past. So we are going to compare whatever, collect this information, make some analytics, compare them to our different groups of patients in the past. So what was these variables in the patients that actually completed the whole round of therapy versus those who didn't? What about those that actually improved clinically compared to those who didn't? What this specific patient, individual, what is the probability that they belong to one group or the other, right?
Gotcha.
Giving that really rich data set back to the clinicians, now they can make more informed decisions that, okay, if I believe based on this and this and that online psychotherapy, just asynchronous connection with the patient is not enough, maybe I add video to it. Or maybe I add medication to it, and that is really helpful because this way you are not really going assigning randomly whoever comes in to a psychiatrist or a psychologist who are more valuable time. You start on the base. Everybody is receiving the things, and you develop this step care model that most probably 70 or 80% of the patients are those initial modules are gonna be enough for them. But we can now define algorithms to escalate or de-escalate patients that, okay, we have been tracking this. We think that this patient would benefit from higher level of care. Now you bump them up. You continue the module, their progress again. And if you feel they are not receiving enough care, again, you bump them up. This way, you really are, taking the most advantage of your resources, and every patient is receiving the exact amount of care they need, rather than some receiving care that they don't need, or some receiving care that is not enough.
Yeah.
So we see our AI analytical part as a complement to our clinical side. That we have developed a standardized and very streamlined solution that is easy to apply. And we have also developed analytical solutions that can route the patients from those initial steps to higher levels of care. So that is how we see the problem. So
yeah.
I think I took like 15 minutes to explain.
No, that was thanks for walking us through. But that that's a huge help for decision-making process and for care as well. But what I'm wondering that first you provided that modular with the vetted data, for verified data, this is the module you should be. Is there a correlation between that modular data you provided to clinic and then the AI data that were patient what got treated? Is there a correlation between those two, or do you run analytics between these two set of data? Say, listen, we provided this module, and here's the data that we're coming from based on our experience and our practice.
Yeah, that's a great question, and the answer is yes. So. A lot of times that when we talk about machine learning, data analytics, it's then people think of some data fishing. That I have this database, I'm gonna find something in it, right?
Yeah.
The challenge that we have is our modules and our analytical algorithms are designed side by side. Yeah. So we are not really just searching for everything and fishing data. We are specifically, we know what went into module number 3. What kind of what was the technique that the patients were taught in that session 3, and we look at the homework and see that whether they really understood that, right? I mean, if we said something and they said something completely different, it might show that they didn't understand it, right? So our data processing is tied to the modules. So we have a really a structured way of data labeling. So, for instance, patients go through 12 weeks of 12 sessions of this therapy. We have 12 weeks of their homeworks. Along with their homework, we have the clinician feedback, we have the patient's feedback, and we have their standardized questionnaire. So we have a complete view of, okay, this is the first session that the patient came in, their severity of the disease was this much, and this is the last session that they improved. So what is different in the last session that is, you can see in the first session, try to really compare these two situations and come up with a way of really finding a path that, okay, this is the path that if they start here, with these different variables, they should end up here, right? And also, I mean, it goes backward as well. So we really intensively looking at the analytics of, how much patients are engaged with different modules, and for instance, what is the dropout rate across each session, and is there a session that has significantly higher dropout rate? Maybe there is an exercise that is too cumbersome that the patients give up. It's like, okay, forget it. And then you can look at that and say, okay, this should be changed because this is actually a stumble, for and a stop button for the patients to go through. Maybe you move it backward. Maybe you get rid of it altogether. So, yeah, it is completely, interlocked.
Yeah. So very interesting. This is a perfect example of AI technology implemented and a very, very good use case. So we cover all those three areas, but what happens to brain scanning piece? I recently introduced somebody. They were saying, there's so much advancements being done in scanning of brain. You can see so much these days that you could see 10 years ago, 20 years ago. Does this interact with any part of that? And what are your thoughts on that technology advancements in terms of brain scanning and reading the brain and trying to visually understand what the problem patient is up against?
Well, they have their own. I mean, as a neuroscientist, I have a high thinking of biological interactions in the brain and how they are giving rise to the problems.
Mm-hmm.
This is the missing part about my story, that how come I came from from a neuroscientist to be working on a startup.
Yeah.
The challenge is that the brain is too complicated. It's nothing similar to any other problems that we have ever faced, right?
Mm-hmm.
In my opinion,
Mm-hmm.
we wouldn't have a breakthrough in our understanding about the brain and brain diseases in the next 20 years, right?
Wow.
The challenge is that, we are really accustomed to linear stories, right?
Yeah.
And that is how we keep track of stuff.
Yeah.
It's like, okay, what's happening in diabetes? Insulin is low. Okay,
Mm-hmm.
good. And insulin is low, the blood sugar goes higher. Okay. But, when it gets more and more complicated, we tend to lose track of those. Our understanding gets worse. I mean, again, still they're tractable. The problem with the brain is that essentially it's intractable. So essentially, so we have around, I don't know, 40, 50 different kinds of neurons. We have uh, more than 10, 15 neurotransmitters, 10 neuromodulators, 20 proteins that affect the firing.
Mm-hmm.
So now when you try to put them all together, the computational power to really understand that, we are nowhere close.
Mm-hmm.
We try to simplify the questions. It's like, I always bring this example. How many times you have heard that vitamin C is good for the cold, and how many times you heard that it's not good for the cold,
Yeah.
right?
Mm-hmm.
The challenge is that it's not that some of those researchers were good researchers and some of them were bad researchers. The
Mm-hmm.
challenge was that they were trying to evaluate their effect in a really, really, controlled situation,
Yeah.
right?
Mm-hmm.
So somewhere that you can linearize the system.
Mm-hmm.
They test their hypothesis there, and they say it's good for the income or for the outcome or not.
Mm-hmm.
And then they try to generalize that to the whole system, which was not non-linear completely.
Mm-hmm.
So depending on where you pick and
Yeah.
what situations you stabilize, your outcome might be one way or the other,
Mm-hmm.
right? So that is the challenge, is that unfortunately, the interaction between different brain areas and the interaction between all these different neurotransmitters is so complicated that we cannot wrap our brain or even our analytical powers around it to really have an understanding. And but that doesn't mean that we should stop.
Mm-hmm.
We should definitely continue what we are doing. We should definitely invest more and more money on understanding the physiology of the brain, understanding the different ways of looking into the brain. But I personally don't think those factors would be coming into effect and how we practice,
Mm-hmm.
for instance, for mental health anytime soon.
I see. Okay. Yeah, there's so many studies being done in that, people, scanning, there's so many advancements in that area, but, yeah, it's taken so many years, but, even for us to get this far, I guess, right? So it's a journey, but it'll take longer. Okay, so let's bring it back to the businesses. Now that mental health, the discussion we were talking about, your solution, companies, business leaders who are listening to, our discussion, or even in families, as these challenges, we're going through, and what's people coming back to offices, or they're working remotely. Business leader needs to manage teams. There's so many people in the team, and they must. Some of those people could be, dealing with some of these challenges that we just talked about. What can business leader, or even in a family, what can you do to help out these people who are maybe struggling with some of those challenges?
I'm now talking completely from a CEO standpoint. I'm not a psychiatrist.
Mm-hmm.
I'm not a psychologist. So
Yeah.
I think it is important to have an understanding.
Mm-hmm.
Educate yourself. Know that, now like when half of Canadians express anxiety, so if you have 10 employees, 5 of them are going to be among that half.
Wow.
Okay.
Mm-hmm.
So educate yourself, know that this is a problem, know that have compassion,
Mm-hmm.
help people walk through their situation, let them know that there is no stigma of receiving care. We
Mm-hmm.
all have this is a medical problem like any other medical problem. It's nobody's fault.
Mm-hmm.
So uh, you really, if you find you develop diabetes, you go to a doctor to handle it.
Mm-hmm.
I mean, there are life changes that you can make that to improve the situation, but again, there are multiple factors going in. So there shouldn't be any shame or any blame,
Mm-hmm.
on why you have this problem. This is something that is happening. So you gotta know, educate yourself. You gotta. It's important that, well, and learn how to deal with it. From a specifics. There are institutes that
Mm-hmm.
provide information, provide tutorial on how to deal with situation with your employees,
Mm-hmm.
and more importantly, uh, try to choose a more uh, you know uh, futuristic and understanding employee assistance program, or
Mm-hmm.
that they really understand and they care about your patient, about your employee, and
Mm-hmm.
encourage your employees to use the resources that they have access to.
Mm-hmm.
A lot of uh, EAPs essentially are counting on the fact that they sign with the employer
Yeah.
and the employees wouldn't use them because they are
Mm-hmm.
charging based on the number of the employees,
Mm-hmm.
and the less employees that use them, the higher margin for them.
Mm-hmm.
So if you find a really good EAP, which is slightly more expensive than the other one, it is definitely worth investing.
Mm-hmm.
So to give you a number,
Mm-hmm.
so these are numbers that I have in mind. It might be a slightly off, but
Yeah.
so 40% of short and long-term disability claims
Mm-hmm.
belong to mental health problems.
That's a big number. Mm-hmm.
70% of the
Mm-hmm.
expenditure on short and long disability claims is belong to mental health problem, because mental health problems usually tend to take twice as longer on disability to be on disability claim as to other situation.
Mm-hmm.
So at the end of the day, the employer is paying for that in some way, right? You are
Mm-hmm.
paying for some insurance
Yeah.
company, and so just remember, uh, 1 out of 3 employees in Canada goes on disability claim at one point through their employment.
I see.
So you might be saving $5, $10, I don't know, $1,000 by choosing an option to just say, well, we have this option, but you are losing way more, in productivity and in paying for insurances. So as always, prevention is much cost worthy than treatment. So that's my suggestion.
So education seems to be the big part on both employer and employee side. Would you say that is one of the obstacles? What kind of challenges you face with Opt in the company? The scaling up that technology, putting in the hands of physicians or putting in hands on a medical expert or in a patients. What obstacles you face, and what do you think the biggest challenge you guys are up against? Is education is part of it?
Well, there are a lot of factors going in, and this is the part that I've been in this now running this startup for and in the startup space 3-4 years, and obviously my mindset has changed a lot, right? At the beginning, I was on this illusion that if you develop a good product, people come and people come and use it, which is nothing further than the truth. Having a good product is not enough. You should have good support, backing of a good sales and marketing team, backing of a reputable organization, good backing of financial backing. So a lot of that is not about your product, is about the organizational approaches, and things that are more in the sales and marketing sort of aspect of the thing that I was not trained in. I was trained a medical doctor and a scientist and researcher. I was not trained as a salesperson. I didn't sell anything, not even a cookie, to anybody before I came and started my startup, right? And I don't have that sales gene or whatever it is, that to present it that way and make it look fancier, and so those are stuff that come and bite you in your end. So I think really from the first point that you're thinking about the product, you have to think about surrounding yourself with the right people who have done this before, who know how it works, who have sold before, who have negotiated before. So those are all things that you learn the hard way, and it's not like that we have yet solved it. Our product, I don't know if it's good or bad, is way ahead of where we are, financially, and where we are commercially. It's way more mature, and so obviously there have been some unbalanced kind of approach that now we should compensate for. So that is the real part that really affects us.
And was you not the only, I think a lot of entrepreneurs, when they, with a good mind, a background in a different fields, they all build product and services, and you go through challenges, and all of a sudden you find out, hey, you need to go out and sell these product and services, right? And I think a lot of entrepreneurs, when they go through, or they start, I was one of them as well. When I started, company. My background was IT, but then you have to go out and sell it. And I think a lot of people go through that. But it's either you got to find the resources, or you got to step up. It's a learning process, learning curve, and you have to step by step go through it and get exposure is a bigger thing. Yeah, you can build a great product without having a proper exposure. It's not going to get, the word's not going to get out.
Exactly.
And especially the product like yours, like there's so much that built into product, educating people in both positions. You can give them a product, but unless you educate them, how to use it, they're not going to find the best use of it, right? So education and training, I think, is probably one of the challenges that you got to get through. But wow, very interesting.
Yeah.
So what do you see in the next few years? What's the plan? What are you guys working on, and where do you see moving forward?
Well, we really feel again about strongly about this two-pronged approach, that to have a high-quality product that by itself increases the care outcome, solves the problem that people have today, and have this analytical approach build up on the side of it, so we can have the next generation of how we practice mental health, right? And I often compare this to Tesla. So I often in my presentations showed people logo of Waymo and Tesla and asked them, which one do you know as a self-driving car? And a lot of people don't even know it, like, what is Waymo, right? Google got into the self-driving car a lot earlier than Tesla, but they still don't have any product out. And I think that is because of their different approach. Google had a top-down approach. They got a car and said, okay, what is the way that we teach the car to drive, right? And they tried to come up with their own solution to teach the car how to drive, which is not as successful. The way Tesla did was bottom up. So what they did was that they made a sexy car and they loaded up with lots of sensors. So people came and bought the car because it was a cool car, because of the battery power and everything. And now that the cars had a lot of sensors, Tesla now could learn how people drive. So they could look at these different scenarios. Okay, this person got into this situation that is close to an accident. What did they do that they escaped from accident, and what did they did wrong that they got into accident? So instead of them trying to teach the car how to drive, they tried to learn how the drivers actually drive. And that is how I see this working as well, that there should be a product out there that actually works fantastic, people want to use it, and there should be these analytical approaches that we learn as we go forward, and adds to the capabilities, adds to the unique value proposition of that clinical part. That's how I see it. I strongly believe about the data, strongly believe about the evidence-based approach in mental health. So yeah, that the approach is going to be investing more and more on the data and analytical sides to enrich that capabilities.
Especially makes sense as you treat patient or you gathering the data, and once you have the data, you can run many different analytics on it and provide better decision making process and better decision points for physicians to make a decision. So definitely over the time, see that as enriching that feature over time. Very interesting.
Yep.
Okay. Where can people find you? Where can learn more about your product, and where can people connect with you?
Definitely. So they can reach me on LinkedIn, Mohsen Omrani, and they could reach me on my email, Mohsen, Mohsen at opt.ca. Opt is OPTT.ca.
Yeah.
They could visit our website, OPTT.ca, or OPTT.health.
Yeah.
And yeah, I would be more than happy to discuss anything, so
Yeah.
please reach
No.
out.
Yeah, no, definitely, as a problem's getting bigger and solutions like yours, these are the technologies gonna help to increase the capacity, as you mentioned, especially we don't know what's gonna come after COVID on a mental health side. But I can see that from my research with the experts that they all, and that guiding in a direction that is gonna get worse. And you're gonna need some sort of AI technology or some sort of tools or technologies to speed up some of the stuff. And I think your product's gonna, help a lot of people in that regards, and it should be, great helpful positions as well, so they can increase their capacity and help a lot of people.
We really hope so.
Good.
We really hope so.
Good stuff. Thank you so much for our time, Mohsen. It was a great, discussion. I learned so much from you.
Oh no, thank you for your time. I mean, I love to talk, so
Very interesting.
thanks for your time.
Okay, thank you so much, Mohsen.
Thank you. Take care.
Okay,
Take
bye-bye.
care. Bye.